Right, I think we shall start. Will that be okay, Sonia?
Yes, I'm ready.
Okay, so just to introduce myself. My name is Darshan. I'm one of the surgical trainees working in Wales. So I'm just going to do this communication and history taking session with you guys for your MRCS Part B. We'll just start just with a short introduction by yourself, Sonia. Just tell us where you're from, when's your exam, and what's
Yes.
your preparation like till now.
Hi, Dr. Darshan. I'm Dr. Sonia. I'm from India, and my exam is on 16th of October in UK, in Edinburgh.
In Edinburgh. Okay, all right. So hopefully preparation is well underway for your October exam.
Yes.
Okay,
Yes. So,
fantastic. So we'll just start with the history taking. I'm sure you've seen results previous sessions where we do a time session. So
yes.
10 minutes, 1 minute reading time of the station, which I'll share the
Okay.
screen, and then 9 minutes of your performance with whatever you're
Okay.
supposed to do. And then we'll followed by feedback after, and then the teaching of what's expected in the exam.
Okay, Dr. Darshan.
Will that
Yes.
be okay?
Yes. Okay.
That's fine. Just call me Darshan. You don't need to be formal.
Okay.
All right, just 2 seconds. I'll just be sharing the screen. Right, so we'll start with the history taking session first.
Okay.
Okay, so let me just share the screen and I'll start the time now. That's just 1 minute reading time. So I'll just share the screen first and then let me know if you can see the screen. I'll start the time for your reading time. Will that be okay?
Okay.
All right, 2 seconds. All right, can you see the screen?
Yes, a screen is visible to me.
Fantastic. So I'll start the 1 minute time. I'll let you know when your 1 minute's up, and then we'll start the session. Okay. All right, your 1 minute time
Okay.
starts now.
Okay. Okay. I'm ready. Can we start?
You ready? Yeah. All right, go ahead.
Yes. Okay. Hello. I'm Sonia. I'm one of the exam candidates today. May I confirm your name and age, please?
Sure. My name's Darshan Raj. I'm 64 years old.
Nice to meet you, Mr. Darshan. Today, I have been assigned to ask you 3 questions regarding your knee pain. And during this conversation, I will be taking some notes. Are you okay with this?
Yeah, sure. Go ahead. Of course, that's why I'm here.
Okay. So, can you tell me how you visited the hospital today? How can I help you today?
Well, I've been having this, knee pain. My right knee's been giving me problems. I've been having this pain for the past 4 months. I've seen my GP. He's been giving me painkillers and all that, but it's not been helping. Hence why he asked me to come and see you today.
Okay, I'm sorry to hear that you are in pain. Are you still in pain? Do you need some painkillers for
I
currently?
mean, I mean, right now, the pain is. I'm sitting down, so the pain is not. It's still there, but it's not as bad as when I start walking and all that. But yeah, it's fine. I don't need any painkillers just now. Just if you can just tell me what's
Okay,
wrong, that'll be great.
okay, okay, sure. We will try our best to help you. Can you tell me exactly which side you are having this pain? Is it on medial side, inner aspect of your knee or outer aspect of your knee?
What do you mean by medial? Like, what does medial
Me-
mean?
I mean, whether you are having inner aspect of your knee, inner side of
Oh,
your knee or
okay.
outer side.
Okay, okay. Oh no, I think it's just the whole knee, to be honest. Like, when I start walking and all that, the pain's just the whole knee. I don't know whether it's on the, inner or outer. Um,
Okay. So did it appear suddenly or means it was slowly progressed?
it's kind of slowly progressed, to be honest. So for the past 4 months, it's just came out of the blue. So it just kind of progressed slowly. I've been seeing the GP for for about 4 months. It's not been helping.
Okay. Is there something that makes it worse or means makes it better?
I mean, movement makes the pain worse. To be honest, like I used to go out for long walks with my dog, and right now it's just like I used to go for half an hour walks, but right now it's just after 10 minutes it's done.
Okay. Is there something which makes it better?
I mean, rest. I mean, once I stop walking, sit down on the sofa and then put some ice pack on it, and it gets better.
Okay. So, on a scale of 0 to 10, can you tell me how much you scale this pain?
I mean, right now when I'm sitting and all that, it's like about 2 or 3. But then when I start walking, especially after I start walking for about 10 minutes, then it goes up to about 7 or 8. I can't
7.
run. I used to be an athlete. I used to go to the gym and go on the treadmill and all that. But right now I just can't go on the.
Okay.
Yeah.
Okay. Does it move to any other part of your body, like in your hip or going to your back?
No, no. No. It's just the right knee.
Right. Okay. And can you describe this pain for me? Like, is it sharp shooting or, stab or, throbbing pain? How is this pain?
I mean, it's kind of a dull pain, to be honest. It doesn't come out. It's not as sharp or anything, but just dull. But it gets
Okay.
kind of worse as it goes along.
Okay. Did you suffer any injury in past in your
Yeah.
knee?
Yeah, I mean, interesting that you asked because I had knee surgery kind of 10 years ago after I had an injury during football. So yeah,
Okay. And does your knee lock sometimes during walking?
yeah, it does. I can hear like a clicking sound. Yeah, so sometimes I think it locks. Yeah.
Okay, clicking sounds are there. And is there any change in shape of your knee you notice?
Come again?
Is there any shape change in your knee
No,
you
not
notice?
that I'm aware of. No, no, no.
Okay. And do you feel like give away, sort of giving away while walking?
Come again? Do I feel like?
Giving away, joint, like, is it like joint giving away while walking?
No, 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 not that I know of. No, no.
No.
Is it
Okay.
supposed to give away?
Sorry, I could not hear you.
No, is it supposed to give away?
No, I'm just asking you
Oh, okay, okay,
to
all right,
make
all right, okay, okay. You got me
this
worried.
picture.
Okay, all right.
Okay. Do you suffer any, joint stiffness in your hands or feet?
Yeah, I mean, sometimes, I mean, I get like stiffness in my hands, but in my knee as well, especially in the morning when I get up. But nothing too significant. It's just the knee, which kind of bothers me, especially when I wake up in the morning.
Okay. I'm sorry to hear that. And do you have any change in your bowel or bowel habits, like
No, 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 not
lumps
that I
or
know of. No,
something?
no, that's fine. My bowels are moving okay.
Any? Okay. And do you have any other medical condition?
Well, I'm diabetic, so I take pills for that, and I have high blood pressure.
Do you know name of that pill?
I think I take glucophage for my diabetes, and then for my blood pressure, I think I take some Ramipril or something like that. So
Okay. From how long you diabetic and hypertension with this blood pressure problem you are having?
I don't know, about 10, 15 years.
Okay.
Yeah.
Are you allergic to any other medicine or
No,
any other significant allergy?
no, no.
Okay. Thank you. May I know what do you do for living?
Oh, I used to be a footballer, so I used to be an athlete, and I retired 10 years ago. After the surgery, I just couldn't play.
Okay.
Yeah.
So do you smoke or drink?
All right, Sonia. So I got to stop you there. Um,
Okay.
I just stopped you at the 6 minute mark. Sorry, it's not 9 minutes. I was just told that we'll stop you for 6 minutes, and then we'll ask you some questions of what do you think, and then we'll go on from there. Would that
Okay.
be okay?
Yes. Okay. No problem.
Okay. So I
Okay.
mean, all
Can
right,
I?
you were doing well. Given time, you have now three
Okay.
more minutes. Given time, I think you would have finished the history. So you're doing really well.
Thank
Okay. So then,
Okay.
can you just summarize briefly for me what you've gathered from the patient?
Okay, sure. Today, Mr. Darshan, 69, 69-year-old patient, came to us with right knee pain from last 4 months. His GP sent him to us, and he is having whole right knee pain, which is slowly progressive in from last 4 months, and it increases on walking and decreases on taking rest and ice packs. There is no radiation, and this is dull pain, and or while walking, patient is having severe pain. He marked it as a 7 to 9, and on rest he is having just 2 to 3, and he is having this locking of knee, and clicks are present, and also he suffers from hand stiffness in morning especially, and he had some unknown knee surgery 10 years back, and he's a known case of diabetes and blood pressure from last 15 years, and he was a footballer, and now he's retired from last 10 years, and after taking the history, I think my most probable differential diagnosis will be traumatic osteoarthritis, or there can be some old ligament injury or meniscus injury, or some rheumatoid arthritis.
Okay. Anything else you'd like to add?
uh, Sorry, I could not hear you. What is it?
Anything else you'd like to add?
I would also consider some spine pathology referred pain. I would like to examine his back, and also some vascular portion also, some hip pathology, and um, I think after that, because I try to exclude the septic arthritis and extra intestinal IBD features also. I don't think patient is having that.
Okay. All right. Well done, Sonia. So I'll just ask you a few questions just to,
Okay.
to probe you further about what you've summarized to me. So, I
Okay.
mean, you have a very good differential list. Well done. You gave a few list of differentials. So tell me, how would you investigate this patient to kind of confirm your differentials and to narrow your list down?
Okay. After a proper history and examination, I would like to investigate this patient by X-ray examination first, knee X-ray, right knee X-ray, and left knee bilateral knee X-rays in standing and weight bearing position, AP and lateral view. And also, I would like to check his diabetic hypoglycemic control, hyperglycemic control, his full blood count to rule out the septic arthritis, and also his diabetic status for that hemoglobin glyco HbA1c. I would like to uh, advise him. That's it for investigations.
Okay. All right. Right. So well done. So you mentioned X-ray. Uh, Good. So tell me, what changes would you expect to see, on a plain radiograph, say, of a patient
This
with osteoarthritis?
Yes, this patient might be having osteosclerosis, and also osteophyte formation and reduction in the joint space.
Okay. All right. So tell me, what are the indications for a knee replacement?
For knee replacement, whenever there will be a decrease in the joint space and severe osteoarthritis, which is means which is disturbing patient a lot, means patient is not able to walk, and realignment is not there, proper realignment of the joint is not there, and it is disturbing patient's day-to-day activity, and also failure of intraarticular steroid injection. Also, we will give trial of intraarticular steroid,
Okay.
and that's
All
it.
right. Well done. So tell me, what are the treatment options for osteoarthritis?
Initially, I will go with the conservative plan. I will advise my patient to have a healthy weight, and some weight goal I will try to give him, and I will divert him to the dietitian also, and involvement of physiotherapist also in this. so that a multidisciplinary team approach can be achieved. And then regular exercise and not non-weight bearing exercise, especially the swimming and some strengthening of the muscles around the joints, and some cycling, etc. And then in pharmacological management, I would like to give this patient some painkillers according to WHO letter, and local heat application to the joint may offer relief, and some physiotherapy or the intra-articular steroids. And in surgical options, I would consider arthroscopy or realignment, osteotomy, and arthrosynthesis, and partial or total knee replacement.
Fantastic, Sonia. So well done. All right, so we'll stop your session now. So just tell me, how do you feel? How did you think that went?
I think I was slow in taking history. I could have done that better. I would have speed up my. I mean, if I will practice more on that, I think I
That's
did.
that's fine. I mean, you did well, to be honest. You asked all the salient questions. You were right that you were spending a lot of time on the history of presenting complaint.
Yes.
I think you were just going through the list of questions to roll out different things, which I could see your thought process. So, but
Okay.
I think you just could be just a bit more succinct and quite a bit more brief. Just tell me. I mean, the examiner should kind of have an impression of that. You're just trying to roll out the top two differentials. I could see you're trying to roll out like
Mhm.
osteoarthritis, rheumatoid arthritis, septic arthritis, but you did well in that aspect. But just to be a bit more brief. Okay. So,
Okay.
I mean, to be honest, it wasn't fair to you because I stopped you at about 6 minutes mark, so you couldn't finish your full history.
Okay.
But in the actual exam, you have 1 minute to read. Take that 1 minute to read properly because there are pointers in the history outside the door.
Mhm.
To actually give you pointers as to what the examiner would want in the station.
Okay.
So take the full 1 minute, calm down, read the history, prepare yourself mentally, and then go in and smash the station. Okay.
Okay. Sure.
So when you go in, I'll just share the screen now. I have to, the slide that we prepared for you, and for the wider
Okay.
audience as to what is expected from the station. 2 seconds. All right. So can you see the slide now?
Yes, it's visible.
All right. So if I change the slide, can you see it changing?
Yes.
All right. So just briefly go through the history. So introduction is quite crucial. You did quite well. So you introduce yourself. You told me your name, who you are, and then you confirm the patient's name and age. It's also good to check. I mean, if the patient has a wristband, just to double check the wristband quickly. And of
Okay.
course, while doing all that, wash your hands. So there'll be an alcohol gel or wipe in the station. So just quick alcohol gel, wash your hands while introducing yourself. So that shows the examiner that you are quite conscientious about hygiene and all that. Quick brownie points. Okay.
Okay.
Um,
Yes.
so and that washing your hands is crucial to every station, be it history taking, communication skills, physical examination. So do it. So just when you practice, just make it so that's automatic for you when you enter the station. Okay. So you were
Okay.
quite good in asking me like what can I do for you? Why are you here today? And simple things like basically cues. So when I told you that I've been in pain, I've been seeing my GP for 4 months, it's not been helping. Just simple things like I'm sorry to hear that, kind of empathy, to show that you have empathy towards the patient. Good things, simple things like that. Try to kind of
Okay.
practice that. Okay.
Yes.
Um, Going to the history of pain. So you did your Socrates really well. I could see that you were asking all the points. So simple things like site, onset, character of the pain, radiation, associating factors, timing, any exacerbating and relieving factors, and also severity. So you went through all of that really well. So I didn't have the impression that you were going through a list. You were kind of asking it naturally. So that was okay. That's really good. Okay.
Yes.
Um, I'm just going through this really quickly. I believe the slides will be shared with you in due course, if I'm not mistaken. So All right, so your differential diagnosis would be, as you mentioned, osteoarthritis, there's ACL injury, and then meniscal injury, and then, of course, rheumatoid arthritis. Okay, so you're asking all these questions that I could see, albeit, I mean, you're taking your time in the history of presenting complaint, but you did ask the question, so points given there. Okay, but just a quick point, just be brief, try to do everything quite rapidly because you have your past medical history, you have your surgical history, you have lifestyle, you have occupation, and of course, last but not least, your concerns. So your ideas, concerns, expectations that you have to ask the patient. Okay.
Okay.
All right, so again, other differentials, septic arthritis, referred pain from the back, extraintestinal manifestations of inflammatory bowel disease. Highly unlikely, but you can ask them if you have time. And last but not least, malignancy. All right. So past medical
Okay.
history, surgical history. You asked all of these, which I think is good. Quick thing again, when I told you in the history of presenting complaint, like this pain's been gradual since the past 4 months, and I had surgery a few years ago. You can kind of quickly catch on that to ask me, okay, what happened? Like, why did you have surgery? What surgery was it? And how has it been since the surgery? So you can get that out of the way rather than going into past medical surgical history and asking me there.
Mhm.
Okay,
Okay.
so just to
Okay.
quickly get it out of the way rather than waiting till the PMH or surgical history to ask me that question.
Okay.
All right, so just kind of link on to clues given by the patient in the history of presenting complaint, and then just ask them quickly, okay, what happened there, rather than waiting, because you don't want to miss good points by the patient. All
Okay.
right.
Sure. Yes.
So summarization, you did really well. Just summarize the salient points in the history, and then just give me 2 or 3. I mean, the examiner just want to hear 2 or 3 of your top differentials, and then I'll ask you follow-up questions.
Okay.
Okay. I mean, I stopped you about 6 minutes. Usually, the examiner in the station will stop you about 7.5 to 8 minutes. They'll give you about a minute and a half to kind of summarize and ask you questions. But I stopped you a bit early. Okay.
Okay.
Sometimes they might stop you earlier because they might think that, yes, the candidate knows what the differentials are, and they just want to ask you questions. So if they stop you earlier and ask you questions, it's kind of a good sign. It kind of shows that you're on the right track. They just want to ask you questions so that they if you give you the right answer, they can give you more points.
Okay. Sure.
All right, so well
Yes.
done on that. So yeah, these are the summarization, and then you had the differentials, which is really good. Investigations. So I mean, because MRCS is a surgical exam, you have to be very surgical in your thinking and what you're saying. In terms of you have to be quite methodical. So when investigations, I like to break it down as to when the examiner asks me, okay, so how would you like to investigate this patient? I would tell them, okay, I would divide the patient into three categories. So bedside, hematological, and radiological test. Okay, so bedside
Yes.
test, simple things. You said history and examination is really good. Look at the news chart, which is the observation chart of the patient. The patient has a news chart or observation chart. And also quick BM, patient's diabetic, and ECG, a 12-lead ECG. Why 12-lead ECG, they might ask you. You can tell them, well, the patient needs surgery, baseline ECG.
Yes.
Okay, so
Yes.
things like that. And then when it comes to hematological tests, so I would say, full blood count, don't abbreviate, always say the full name. So full blood count, urine electrolytes, liver function test, CRP, group and safe, uric acid, joint fluid analysis.
Okay.
And then rationalize as to why you're doing this test. You mentioned full blood count for septic arthritis, which is good. Okay, but uric acid could be for gouty arthritis.
Yes.
Okay, you can do a serum
About
calcium.
yes.
You can do a calcium level as well for pseudo gout. Okay, so all
Okay.
that. And then radiological tests, you can say I can do an X-ray of the knee, standing and weight bearing, AP and lateral. I'll start with X-ray first. If I can't find anything in X-ray, I will discuss with my senior, so my registrar or consultant, and see if a CT or an MRI is needed.
Okay. Sure.
Okay, so because at this level, they're just testing your level as an SHO, which is like a senior house officer in the UK, and they're not
Yes.
testing Yeah, it's not an MRCS exam where you expect to tell like MRI and what MRI indications are.
Okay.
Okay, so
Yes.
basic test first, and then CT and MRI if I want to speak to your senior. All
Okay.
right. So
Yes.
the next question I asked you was, you mentioned an X-ray. So what are the changes? Okay. For
Yes.
osteoarthritis, the mnemonic is loss. For RA is less. Okay.
Yes.
LOSF, loss of joint space, osteopenia, subchondral sclerosis, and subchondral cyst. Okay. For
Yes.
left, for RA, the E is just erosion, so joint space erosion. That's the only difference. All right. So
Yes.
indications for knee replacement. So those three, you mentioned all three. So pain relief, improvement of mobility, correction of deformity. Okay, and last but not least, treatment. You can say from the start, I would divide treatment into medical or conservative or surgical. And then medical, you mentioned all the right things. Surgical, replacement, arthroscopy, and arthrocentesis and all that. So you did all the right thing. So you did really well, Sonia.
Thank you very much.
It's just you need to be quite brief and succinct in your history taking. Just practice. Practice with your friends. Record yourself while practicing with your friend. Watch the recording after and time
Okay.
it. And then your friend and you can critique each other.
Sure.
Ideally, your friend should be someone who's also taking the exam in October.
Yes. Okay.
And that applies not only to you, but applies to everyone who's listening to this recording, who's sitting for the exam soon.
Okay. Sure.
All right.
Okay. Thank you
So
very
that
much.
concludes the history taking for your knee pain. I think we have another communication skill station.
Yes.
Uh,
Thank you for your participation, Sonia. Darshan, thanks for your nice explanation for history taking.